Hello, welcome to Renew Education. This is another case study looking at something that's kind of interesting here. I would love to hear comments about laser and in particular laser cleanings. I see patients from time to time that tell me that they had lasers cleaning their teeth. This is an example of a disaster, and this is where I really have a problem with lasers, and you don't really know which laser they're using. There seems to be a very high level of technique sensitivity when you're using lasers across hard tissues, especially if you're trying to remove calculus on the roots of patients, and that's this case right here. A patient had come in and I didn't know what they were coming in for. I assumed it was the area in the upper left quadrant, but it actually was not. The patient was concerned, really just wanted a second opinion about what this particular tooth is dealing with. And that is right down here at number 24. That actually has a little bridge on it. Now, how do I know that that was caused by the laser? Well, from the interview that I had with the patient doing the exam, I have not seen the patient since. Actually, it's been about 6 months since the patient's come in. But the patient had mentioned that didn't have any problems prior, et cetera, having this cleaning, that the dental hygienist had just gotten this wonderful new laser tool, and now you have these problems. So, a patient, what do you tell the patient? So I recommended that the patient go back and actually talk to the doctor about what they think, what we've kind of talked about a little bit first, obviously, to see what the doctor is willing to do in this case and try to take care of this in their own office. And hopefully that is being taken care of, because this is an unfortunate case where it becomes hopeless. So I'm still going to evaluate that upper left side for you. We have a light green area. We have to yellow. We have some constriction issues when you look at the whole mouth. We have really good density, so we have a green there. And the only orange I would kind of give him is looking at some of the failing teeth. He does have chips here, and then he has this kind of uneven pattern of his bite a little bit, but he also has this bridge, which means that there was a failed front tooth there. So I'd probably give him an orange just because I don't know enough about how he's biting across his front teeth. So let's look at this case here. Let's look at this area here first. This is the problem area here, and you could see that it's really chunked out when you look at it here. Let me move the cursor over. Probably not going to see, this is a good PA one. I don't have a PA, but here's that tooth cutting across right here. Oh my God, it's such a bummer. There's so much tooth structure missing. Another way to look at it would be from the occlusal viewpoint, and I've got my cursor right on it right there. And as I go down, you can just see how much of that had been destroyed right through there. So that's that's just such an unfortunate spot. We're right on the bone. And it's nothing like you've ever seen before. It's just clean. There's no decay, and this hygienist just really ripped apart the tooth, not really knowing just how powerful that laser actually is. So that's quite damaging. Hopefully, laser education will hopefully get better, or they'll get more specific. This patient has now an endodontic problem. He's got this gum problem. He did mention that the doctor had said, well, let's put a filling there, but I'm like, this is not a filling case. He's right on top of the bone, and that's really bad. If you put a filling here, it's gonna cause a lot of bone recession and cause this to be worse. He also has a big endodontic issue now because of that. She's into the nerve. So if you extracted this tooth here, you've got about 6 millimeters. Well, we have to look at the constriction area, which is, like I said, is problematic. I've given a yellow on this case here. But if you had a 3.5 and you had this kind of width, there's a possibility of this working out okay because the facial bone is so good here. That's what's kind of cool about this one. It's not a complete loser when it comes to can you do an immediate placement or will you maintain the bone? And this is 13. So if you're only going 11, you have a 3.5 or a 3.2. I've seen those. You could restore this with an implant right here. The problem with restoring this with an implant here is that now what are you going to do? Are you going to put a bridge across the implant to the natural tooth? That's one of those kind of so-called no-nos, right? So if you really want to do an implant here, I guess you do that. But where does it lead you is the point. Here's the other missing tooth right next door. And you can see that facial plate, because the facial plate was so heavy and strong, this is without a graft from I don't know how long ago. And look at the bone that was preserved around that facial plate. When the patient has a very strong facial plate here, you're going to maintain the bone, graft or no graft. It doesn't make a difference about the grafting, and this is a perfect example of that. So, to make things simple for this patient, you basically have to just take this tooth out and do a 4-unit bridge across the 4 anteriors, relying on these 2 central lateral lower teeth that are there. So that's pretty straightforward to me. I would use traditional dentistry, maybe even just do a Maryland bridge type of prep with Emax. But, it all kind of helps talk to the patient about it, about what they have, what's going to work out. They have this. I don't know how long that's been in there. So let's go up to this area here. This is an interesting one. And the reason why I want to talk about this one in particular is how good the bone looks and why didn't this patient actually get anything done. I suspect it's just purely a financial situation for the patient. And somehow the patient thinks that chewing on 50% of the mouth is okay because he's definitely not chewing over here and he's putting more load across here, but he's chewing most everything over here. Maybe that's enough. We have this wisdom tooth here, and the reason why I want to bring that up is because this wisdom tooth in particular has actually pretty good bone around it. So I was first looking at it going, wow, there's this big defect going on here. And actually the defect is not that big because the area here is very similar bone here and not a lot of bone recession here either. So the bone naturally would progress probably anyway with teeth there, probably from about here to here. So maybe there's a defect around that, second molar side or between, maybe they had a little vertical bone loss like over here that was going on around that second molar. But overall, that's not too bad. So we're in the molar position here, and I'm just going to kind of indicate where that is right here. So that's where we're at. And here's what it looks like. It's great. It's very wide, very generous, and just like perfect bone. So if this is your first implant and you're a lefty because it's up in the upper left, this is your case. If you're a righty, then you learn, of course, the old trick of like going cross arch to restore it. The problem you always have is the angulation. So use pins, take your PA x-rays to make sure that you're going into a compressive load with the lower appropriately, and you're going in the line angle in which the other teeth are going. So you're going to want to be, obviously putting that implant in right here. Now here's a conundrum. Here's my conundrum all the time when people maintain wisdom teeth here and I don't restore the second molars. So what do you do in this case? Because you put that one molar in, they get their primary occlusion back, and then you get this weird gap. And then the patient's like, well, what do I do now? Now they feel more of a gap because now you're closing in. Now they have a giant gap. They don't complain for some reason about that. But they start to complain when you put a molar here and you got this space here. I don't know why, but they will. So either they take it out so they don't have a reference and then there's no gap. It's just ends right here and you don't have to worry about anything there. But, you know, here's where the patient can open up wide. He's got a fairly long arch. And if you're inclined to put in one there, you do have enough room. Maybe, let's just measure this real quick. You do a 10 millimeter implant. This is 8.7. You do a little bump into the sinus. You put a 5x10 here. That would be adequate for that site. And then you have 2 implants that go into this area here. So that would restore it, maintains that feeling for the patient with that third molar, doesn't create some gap issues that they'll complain about later, and that would be it. So here's a rare opportunity that I actually feel like, I would be placing a second molar implant because the patient is not restoring that upper left side with implants, and I feel it's a financial situation. Getting him to invest in 1 implant's one trick. Getting him into 2 is nearly impossible. So we'll see in the future if this patient comes back after learning a little bit more about that front zone. I suspect if the doctor takes care of that for the patient of no charge, the patient will be fine and just kind of move on. But that is a problem. If you do have these and you're a hygienist watching this, please be careful. This is where patients end up. They go shopping or wanting second opinions. And sometimes they don't even tell me what they want the opinion about. So they come in for the free exam and they kind of trap me in a way where I explain to them what the problem is and possibly, you know, how to solve that problem when in fact they're wanting to get my opinion based or to compare to from my opinion towards the doctor that they feel wronged them. So they're getting that second opinion, but they're looking at it more like, hey, can I get your opinion to send to the current physician, current dentist to deal with the problem on their dime. So anyway, that's this case. Same as always, YouTube, check us out, like us on Facebook, subscribe to us on YouTube. We do broadcast, live broadcast streams across Mixer, Twitch, YouTube Live, and Facebook as well. So stay tuned for any others. If you have any questions, please just drop them in, but probably better to come to one of the live streams. I don't answer to our channel's questionnaires there too much. Maybe one of the staff will, but I typically don't. So take care. Cheers. Thanks for joining.